ago, and the median was about 80% in both urban and national areas. That is, the survey results were about 80% of what you'd get from antenatal clinics. This is what's led the UNAIDS now to recommend in those countries that have not yet done these national surveys, and they're still relying on studies of pregnant women attending antenatal clinics as the barometer of HIV prevalence in the whole country. They're now what they're proposing to do is to take that antenatal clinic data and adjust it by 80%. So deflate it by 80% based on these sorts of analyses.
Well, what are the missing bars in the data? Or no data? What is the variant?
I guess it was not available in the rural areas. So, the national household surveys are thought to be the most reliable in areas or countries where we have generalized epidemics, where the epidemic is transmitting broadly through the general heterosexual population. But in countries where we have what are called concentrated epidemics, where it's concentrated in high-risk groups, such as intravenous drug users or gay men or among homeless, where it's difficult to get adequate representation from household-based surveys, other methods need to be developed. What about the United States? The Centers for Disease Control estimates that U.S. HIV prevalence is currently 1.1 million in their latest estimates. What's that based on? It is not based on a national household survey. Basically, it's based on their latest estimate was based on a back calculation approach, or I'll call it the iceberg effect. So basically, AIDS cases are reported to a surveillance system. So that's the blue, the tip of the iceberg. And also, what else is reported to the U.S. national surveillance system are people who are tested with HIV before they get AIDS. So they're screened and they're identified as HIV infected, but they're not yet symptomatic with AIDS. So that's the blue stuff is the tip of the iceberg. That's the data. And the basic idea is that there's a lot of unseen HIV infection out there that's still incubating, and that's the yellow part. And the idea is to use the blue part together with information such as the incubation period to glean information about the entire iceberg. Now, the original version of back calculation, which actually I worked on with Mitch Gale, who's here, was the very tip of the iceberg, was just looking at AIDS cases as the data. But in recent years, there's now another data stream, which are people who don't have AIDS but are being tested and screened at voluntary counseling and testing centers. And that led to, so using all of the blue, both the dotted and the solid blue, has led to an extended back calculation approach, which was developed by Phil Rose, among others, at the Centers for Disease Control. And so basically what this approach, it's kind of a competing risks approach, that people can get infected, and so that's the I part over here, and they get infected, and then and after they're infected, they can either be diagnosed with AIDS, or they can be not yet get AIDS, but they go in and they get tested and their HIV infection is discovered. The data is the blue stuff. So it's a time series of counts of AIDS cases and counts of people who are identified as HIV without AIDS. So that's the data. And then the idea is to do, and also to use information about the incubation period of disease. So the blue stuff is what's known. And then it's a deconvolution technology, which basically allows you to go backwards to figure out the risk that of people being screened for HIV, coming in and getting tested at testing centers, and most importantly, getting at that, which is the underlying incidence of infection rate. And it's this technology which is what created the latest CDC estimates that was published in JAMA that there were 1.1 million people in the United States currently living with HIV infection. Now, if you actually look at the confidence intervals that are published in the MNWR on those latest estimates, they don't quite pass the gut test. They're extremely narrow, and if you look, it's about between 1.06 million up to 1.16 million. Seems very, very narrow, and in fact, those confidence intervals aren't accounting for all the many sources of uncertainty. While they may be accounting for Poisson variation, they're not accounting for all the modeling that went on here, including the incubation period, the completeness of AIDS case reporting, the completeness of the HIV diagnosis reporting, and then there were these parametric models that need to be assumed for the HIV, the hazard or risk of being HIV tested, and also a parametric model that's needed for that I function, for the HIV incidence rate function. But one of the products that come out of it is this incidence function of HIV. And this was one of the products or results of that back calculation, which is the U.S. HIV incidence infections per year between 1977 to 2006. So this is the back calculation, and a parametric model needs to have been assumed, and you can see here that the parametric model that they used was a step function. And in fact, for this to work, you need to assume a very long last step. There it's about 3 years. And the reason they need to assume a long last step, basically the model is assuming that infection annual incidence is constant for the past few years, is because there's very little information in the data in AIDS cases because of the long incubation period about what occurred in terms of new infections most recently. So this last step is fairly unstable. But it does say that it's about somewhat over 50,000 people were infected in the past year. So it gives you some broad estimate, but it's not one that you could really hang your hat on in terms of what the current HIV incidence rate is. And in fact, if you really want to monitor the HIV pandemic, what's of most important is what the annual number of new infections is, because that's where HIV prevention efforts are all about, preventing new infections. So what I want to talk about now is this other metric for measuring the epidemic, which is what is the current HIV incidence rate for levels? How many people are getting infected each year? That's the true, I believe, leading edge of the epidemic. So what technologies do we have for estimating current HIV incidence? First, there's this back calculation or deconvolution approach, but again, it doesn't really provide good, reliable estimates of the recent infection rate. The more traditional approach is a cohort study, or the longitudinal follow-up, where you take uninfected people and you follow them forward, and you look to see how many people get infected each year. The problem with that is there's no good national longitudinal follow-up studies that will be studying HIV incidence. So it's hard to get a representative follow-up study. A third approach is to look at changes in HIV prevalence in surveys, such as we have these demographic and health surveys. These are national household-based surveys. These are being repeated now in countries. So if you can look at the prevalence at 2 points in time, maybe from those two cross-sectional looks you can infer something about incidence. So there's some sort of balancing equation that the change in prevalence is equal to the incidence of new infections, and then you have to take out HIV deaths, and then you have immigration and immigration effects. And so there's a lot of uncertainty in this part of the, in that part of the equation. So this has not been, is promising, but has not really been come to fruition yet. The last approach is this biomarker approach.